Hi, hello, hello, hello. Happy Thursday. Welcome to this week's live training. It is already October. Not sure how we got here so fast, but here we are. We're going to embrace it. Give everybody another minute to hop on who wants to hop on. Um, Hello to everybody who is watching on Instagram. Hello to everybody that is watching in the Clinical Connections Mentoring Facebook group. Um, Thank you for being here. October means spooky season is here, right? Though I know for some people, spooky season started way back August 1st, not for me. My Halloween decorations don't come out until October 1st, and that's exactly what I've been doing all this week, kind of just decorating my house for Halloween. So thank you again for being here. Today's live stream should be a lot of fun because it's all about storytelling. Since it's October, it's spooky season. I thought I'd just kind of come on here this week for today's live stream and just share some stories and experiences with a little twist of scary. So we're going to call today's live stream Scary Stories, the Patient Edition. So some of you may or may not know, but my husband is also a physical therapist. And so for the first 4 years of our career, we worked together in the same for the same company, same setting, all that good stuff. So today, the stories I'm going to be sharing are scary stories of experiences that either he or I have had with patients during our careers. So in clinical practice, we know that scary situations with patients often come unexpectedly, right? That's what makes them scary. We're not ready for them, whether it's how a patient acting a certain way, patient having a scary response to an intervention that we've provided, or patients just kind of being scared themselves of what's to come. These scary situations will arise. So for today, what I want to do is share some of the situations that I have experienced, and then what I did about them, and kind of how I got through them. Right. And my hope is that by me sharing my stories, you can feel more prepared if you find yourself in a similar situation. Okay. So for anybody new here, I am Dr. Jody Miller. I'm a physical therapist and mentor to PT students and new grads. I've worked in just about every setting there is for PTs. I have worked in hospital-based outpatient a lot. I have worked in home health. I've done pediatrics. I've done early intervention. I've done home health. Did I already say that? I did travel PT. I've worked in acute care. I've done oncology. Most of my career was in skilled nursing facilities, and I was also the rehab director of a skilled nursing facility. But now I have my own cash-based practice where I work with gymnasts in the Tampa area. And I am the owner of Clinical Connections Mentoring, which is where you are now. Thank you again. So what I'd like to do, if you are watching live, whether on Instagram or in the Facebook group, please type live in the comments or the chat and tell me where you're watching from. I like to know who I'm talking to. Same thing if you're watching the replay, please just type your name and where you're from in the comments. Also, while you're typing in the comments, I want to know what scares you the most about patient care. What's your biggest fear when working with a patient? So, like if somebody said, "What's your biggest fear when it comes to being a PT?" What would you say? So go ahead and drop that in the comments as well. Okay, I'll give you all a minute. I think if any PTs are watching, your most fearful thing is the words, "it depends." All right, so let's start with some stories. So the first story I have, literally today is all about stories. So the first story was a patient. It was probably my first year as a new grad. I was working in a skilled nursing facility in North Carolina, working with an older patient. I can't remember her diagnosis, but we were doing gait training. I had gotten her out of the bed. I wanted her to walk down the hall. We weren't going to go far. I knew she wasn't going to go far. I wanted her to just walk a little bit and come back. And I could already tell she was already scared. She was afraid of falling. So she had her walker. I was, gait belt guarding her. I was standing her behind her and to her left side. I remember it clearly. We were walking, we had made it to the door, and then all of a sudden she freaked out and just started screaming and decided to sit down. Luckily, because of where I had positioned myself, She sat right onto my knee. And then just started yelling for help. And I had to call, I was like, okay, hold on. You're fine. You're literally just sitting on my leg. I was kind of in a lunge position. So I calmed her down and was able to tell her, okay, let's just stand right back up. You're just sitting on my leg. Stand right back up. We'll turn around and we'll go back to your bed. And she was able to calm down enough to do that. But that was quite scary, especially for a new grad. I didn't want a patient to fall. I feel like that might be a common fear that a lot of new grads have, is they don't want to have a patient fall on them. But I think for me, what helped in that situation was I already knew ahead of time that she was scared. She's afraid she was going to fall. So I knew how to position myself. And then the ability to calm her down. She never hit the floor. She literally was just sitting on my leg the whole time. I was able to get her to stand back up, turn around, walk back to the bed, and she was fine. Okay, so story number 2. Okay, so with this one, I was working in outpatient. Again, I was a new grad. This was probably within 6 months of me graduating, working in hospital-based outpatient. I had a patient who he was coming for, it was something with his ankle. I can't remember if it was a fracture or what it was. But he was in a boot. He was in a walking boot. He lived in a group home because he had some cognitive delays. So I had gotten him supine, took the boot off because I wanted to do some manual, improve some range of motion to his ankle. So I had taken the boot off and I was sitting at the edge of the end of the bed working on his foot, and his boot was on the floor. And I looked down on the boot and a whole bunch of roaches were crawling out of his boot. He had no clue about it. Naturally, I wasn't scared, but I was kind of grossed out about it. But imagine, a boot sitting right by my feet, a whole bunch of roaches crawling out of it. So I what I did is I just told him to relax, just lay down a minute. I went over, found another PT, told him, who was not working with the patient at the time, told him about this situation. He gracefully walked over, grabbed the boot, and then he put it in a bag, but was able to somewhat clean it out for him, because clearly the group home wasn't taking care of it. Whether they knew about it or not, the fact that he had roaches in his boot tells you something a little bit about maybe his cleanliness and then the cleanliness of the group home that he was living in. So the other PT, while I finished my treatment with him, was able to kind of take care of that boot, clean it to the best of his ability. And then we were able to put it back on for him. I'm trying to remember, I think we did kind of mention it to him that we had cleaned it for him. But I will say all the other times after that, he came in and he was fine. There were no more roaches. But that was story number 2. Definitely did not expect to see that when I took a patient's boot off, to see a whole bunch of bugs coming out. So that was story number 2. Story number 3, we're going to go back to a skilled nursing facility. So this was a facility in Florida. This, I had been working maybe 5 or 6 years at this point. I had to go in and evaluate a patient. I can't remember her diagnosis, but I do know in her past medical history was dementia. So I kind of knew what I was walking into as far as dementia. But with anybody that's worked with somebody with dementia, you never know kind of the where they are in their dementia, right? Are they that happily confused? Are they the mean type? Are they, where are they in their progression of dementia? You don't really know when the diagnosis is just dementia, right? So walked in, kind of prepped myself for possible whatever, anything coming with dementia. She was sleeping. I had to wake her up, and she was not happy. She wasn't, I think, more unhappy that I had woken her up, but I was doing an eval, so I needed her to get up and walk, all that good stuff. She was kind of that, I don't know if anybody's ever heard the term, she was a walkie-talkie, so she didn't need a lot of assistance with her. It was more the cognitive delay. So she, obviously very confused, didn't really know where she was, but from a physical standpoint, she was pretty high level. So I had gotten her sitting up at the side of the bed. Again, she was still mad. All I wanted her to do was walk just a little bit, just so I could see her ability to walk. And I maybe pushed a little too much because she started swinging at me. literally swinging punches at my chest. But I was able to kind of see that coming, and I was able to back enough where she couldn't connect with me, but she came quite close to hitting me in the chest. Um, so that was kind of a scary experience for it's I had worked with patients with dementia before, but not that level of angry. Um, and so what I did in that situation, I kind of knew kind of what to expect. And because of that, I was a little bit of a step ahead of her and was able to back up so I didn't get hurt. But that was clearly the end of our eval. I told her, fine, we are done. You don't have to walk. You can get back into bed. And that was kind of the end of that situation. Um, yeah, so that was a physical scary, right? Nobody wants to get hurt, especially as a PT when your intentions are just to help the patient. But her level of confusion and anger was so high that she was to the point of physical harm to others. But again, she went back to sleep. I think actually went back later that day when she was awake and she was a lot more cooperative. And I was able to assess her gait at that point. So I think part of it was that I woke her up, but also the dementia, her not knowing me or where she was or any of the things. Okay. All right, let's move on to story number 4. This is a story of my husband's. So we were working this was outpatient again, hospital-based outpatient in North Carolina. I'm not sure, it was either somewhere between his first or second year as a new grad. But he was working with a patient. They had been doing Therax gait training. I can't remember the diagnosis for that patient. But he had allowed the patient was doing fine with all the Therax and everything, allowed him to sit down and rest. And the patient suddenly started talking really funny. He wasn't making any type of sense, kind of had that blank stare about him. Luckily, where the PT department was right next to cardiac rehab, so he had access to he checked his blood pressure, checked kind of oxygen, and then also was able to check his blood sugar. And when he took his blood sugar, he found it to be like in the 20s. So again, this was hospital-based outpatient, so a little bit of luck on his side. He took him straight down to the ER, and like he literally threw him into a wheelchair, wheeled him right down to the ER, and said, we need to help this man. His blood, because he had already checked his sugar, he was able to tell them right away what was wrong. His blood sugar's in the 20s. We need to take care of him. And they did. And the patient ended up being fine. But I think that's also a very common, scary story for clinicians, especially if you are a newer grad. Somebody, an outpatient who's assumed to be quite stable, all of a sudden has a quick change in their status. What do you do, right? So he knew, you've got to check on all the vitals, and luckily he was able to check for the blood sugar with the glucometer that was in the facility to find that that was the problem. Okay, so kind of another scary story we had to be quick about, because that can be, somebody's blood sugar in the 20s, not a good end result if you don't do something about it. Again, because we were in hospital-based outpatient, he could take him right straight to the ER. Okay, story number 5. This is back to me. One of my stories. This is a more recent story, probably within the last 4 years. I was working in acute care in an oncology hospital. So every patient there had cancer. Don't remember the type of cancer that this patient had, but he was obese. He was over 300 pounds. I had gone in with the occupational therapist. We knew that we needed 2 people because of his size. So we walked in to do, it was a treatment. We were doing bed mobility, really just we wanted to get him to sitting at the side of the bed. So we were able to do that. If I remember, maybe he needed mod assist between the 2 of us. Like he could do it pretty good. He could get himself to sitting up at the side of the bed. But as soon as we got him sitting, he became diaphoretic, had that blank stare, went pale, and actually fell backwards. Because he was sitting on the side of the bed, he fell backwards. So he was laying kind of perpendicular in the bed. Basically, I was in front of him and the OT was behind him. So I think she was trying to get him to put a gown on, and I was just assessing his sitting balance when all of this happened. So because the OT where she was real close to the nurse's button. So she hit the nurse's button. And then we, between the 2 of us, had to dependently get him back into the bed. And what had happened is he had gone orthostatic. So The nurses were able to come in, but because we were able to quickly get him back into the bed and positioned properly in the bed, we did Trendelenburg the bed as well. And then his blood pressure kind of got back to normal, and he woke up and he was fine, but it super scary, right? That's another one of those, another story where you expect the patient to go one way. Granted, we were in acute care, so we kind of knew he was not as stable, but still not really something you expect. But again, we had positioned ourselves, one, because of his size, two, you know, anytime you're in that inpatient type setting, you want to position yourself where you can protect the patient best. So because of where we were, we could quickly get the help from the nurse, and then we could quickly get him back into bed. He never hit the ground. He just fell back into the bed, and he ended up being fine once his blood pressure kind of regulated back to normal. All right, so story number 6, back to another story of my husband's. This was back in the hospital-based outpatient setting. Again, I don't remember when this was, sometime within the first 3 years of him working. He had a younger female patient who had recently had an amputation. He had been working with her for a few sessions. She came in and just blatantly stated that she told him that she wanted to end her life. Not really something you expect to hear in physical therapy, but I think because of the relationships that we build with a lot of patients, they start to trust us more. They build that rapport with us and feel more comfortable with us than other healthcare providers. And for her, that was him. And so she just told him, you know, I'm thinking about ending my life because the depression and everything that came with the amputation. I think she had some other comorbidities, and that maybe played into why she had the amputation. I don't remember fully, but there was just enough emotional and mental components to what she was going through that she thought the answer was to end her life. So I told my husband about it. He made the decision to call her physician and said, you know, she's told me this. How did we want to proceed? And I'm not really sure how that story ended. But I think the scary story here is that the patient told him that. What do you do if a patient has told you they want to end their life? So I think he did sit with her, kind of talk her through a little bit, but then the major decision was for him to call her physician and tell her primary care physician, and tell her what she had told him, and then figure out how to help her from there. Okay. All right. So the last story I want to share is mine. It's a very interesting story. I wouldn't call this one really a scary story, but more of an unexpected story. This was working at a skilled nursing facility when I was traveling. It wasn't the greatest facility. It was one of those facilities that this was back in the time of rugs. So they wanted everybody to be in that ultra high level. So they basically wanted everybody to have 720 minutes of therapy a day, regardless of their physical ability. So super low level patients, we had to spend 90 minutes with a day. Even super high level patients, we had to treat for 90 minutes a day. That itself is a story for later, which I will share later. But back to the patient. So I was instructed to see this patient for 90 minutes who had not walked in over 2 years. And so I wanted to figure out a way that I could properly bill this patient for 90 minutes of therapy. I wasn't just going to do random things just to pass the time. I wanted to figure out something that I could ethically bill 90 minutes of physical therapy for this patient. So I walked into his room, found out, again, he told me, you know, it's been 2 years. I cannot remember his diagnosis at all. I'm not even sure it was anything significant. I think, again, with him, it kind of went back more towards mental behavior, and just basically him just kind of giving up. Something originally brought him into the hospital, which then brought him into skilled nursing. He's basically a long-term care patient in this facility. And he just had stayed in bed for 2 years with no motivation to do anything. So I got him sitting up at the side of the bed. I was determined to find something that was going to motivate this man so I could do true skilled physical therapy with him. So I sat with him for a very long time. and just talk to him. A lot of motivational interviewing, right? So I was like, okay, tell me what is something that you really, really want to get back to, right? I know you don't want to be here in this long-term facility. I know you don't want that. What is something that you really, really want to get back to? He looked me dead in the eyes and he said, I served in the military, I can't remember which branch, years ago. And something that I really enjoyed a part of that. I was like, okay, well, what was that? Like, I'm thinking, okay, I can have something to work with him here. He said, well, what I really want to get back to is oral sex with men. And I just looked at him straight in the eye and I said, okay. Then he proceeded to tell me stories about it, which was fine. So again, this isn't a scary story of, oh God, what do I do? It was more, that wasn't what I was expecting him to say. But what it did was allowed me to connect with him. He suddenly trusted me and built a really strong rapport with me to the point that the next day he walked 4 steps in the parallel bars with me. By the end of the week, he was walking the full length of the parallel bars. And then sadly, our contract got canceled and I have no idea what happened to that patient. But because I took the time to sit with him and really just kind of let him talk and let me, be heard. He trusted me. He did tell me something that I wasn't so much expecting, which was kind of the scary story. I was not expecting that. But on the flip side, he trusted me. And because of that, I was able to get him out of the bed and walking in parallel bars, something he hadn't done in 2 years. Okay. So these, like I said, these are just some of the scary stories that I've experienced in the past 6 years. I'm sure there are very many more, but these are kind of the ones that really stand out for me. But the moral of all of these stories is really just kind of be ready, be prepared. You do not know, there's no way that you can always know what's coming. It's impossible, right, to know what's going to happen with every patient that you encounter, but you can kind of prepare yourself for most of those situations. So if you work in acute care, whether you're a student on a clinical or you've taken a job in acute care, understand that these patients are not stable, right? Their acuity level is on the lower end, right? So think about what could happen based on that patient's current diagnosis and any of their comorbidities. So if someone has a history of blood pressure issues, be prepared for possible orthostatic hypotension, right? Like the story I shared earlier. If a patient has any type of precautions, be prepared to monitor their ability to maintain those precautions and kind of you be ready if they're about to break them, you're ready to protect them from that or cue them or whatever. And then also just be aware of the signs and the symptoms of any acute exacerbations of any of their comorbidities, right? It's not just the main diagnosis that you're aware of, it's also the comorbidities that can have an effect on somebody that's in an acute care, right? Be aware of what to do if those things happen. So like my patient that went orthostatic, right? We knew right away. Well, he laid himself down, but we called the nurse and then we got in position and we knew right away to turn down for him. Okay. When you're working on a patient, working with a patient, maybe you're doing gait training or you're doing transfers, right? Think about where might that patient fall based on whatever you're doing, right? Which direction are you going during a transfer? Where do you need to stand when you're walking with them? And think to yourself, where can I position myself to prevent this person from falling or to help them if they do fall? Right. So that first story back in skilled nursing, I already knew the patient was really fearful of falling with gait training. So because of just that alone, I knew where to position myself. Now, when she freaked out enough that she sat down on my leg, I was ready for it. She literally sat right on my leg, no problems, and we were able to keep moving on. Okay. So when you're doing gait training, doing transfers, where can you position yourself? Where do you think that patient might fall if they were to, and if they did, how can you stop them? Okay. If you're working with someone with dementia or confusion, just try to be best aware of their cognitive state and try to kind of be one step ahead of that. Think about how they might react to what you are asking them to do. Remember, we talked about there's different types of dementia wherever they are in their dementia progression, and just be prepared for that. Okay. you're working with patients who maybe have experienced loss or a traumatic event, think about where they are in their current emotional or psychological state, right? Is there anything that you need to be looking out for? Who do you need to contact if they tell you something? That kind of goes back to the story of my husband, and then with the patient that said she wanted to end her life, and then a little bit more with that last story that I shared. What did I need to do to protect that patient? Okay. So in all situations, just remain calm. Getting excited or freaking out will not help the situation at all. Okay. Think through what is happening right now, what needs to be done quickly and safely for everybody involved. That includes the patient and you, right? You also do not want to get hurt. Okay. Chances are you will likely experience a similar situation or find yourself in an entirely different scary situation from the 7 examples that I shared with you today. But if you've prepared yourself for most of those possibilities and you remember to stay calm during that situation, you'll likely be just fine and live to tell about it like I did. All right. So I want to thank you again for watching, whether you are watching on Instagram or you're watching in the Clinical Connections Mentoring Facebook group. If you have any questions about what I talked about today, please feel free. DMs are always open. Send me a message or just drop your comments here below, and I will definitely come back and respond to them, whether you're watching live or you're watching the replay. If you drop something in the comments, I will definitely come back and respond. Or like I said, if you just want to message me, go ahead and do that. I'd love to talk to you there too. I hope you have a great rest of your Thursday, and I'll see you next time. Thanks for coming.